Good morning, dear doctors, ladies and gentlemen. We welcome you to the 2018 PSMID Pfizer Interactive Consensus Meeting. And now, may we ask everyone to please rise as we start this morning with a prayer.
Hear our prayer. We are your children, and we've gathered here today. We've gathered here to pray. Hear our cry. Oh Lord, we need your mercy, and we need your grace today. Hear us as we pray. Our Father, who art in heaven, hallowed be thy name. Our Father, hear us from heaven, forgive our sin, we pray. Sing it again, our Father.
Please remain standing for the Philippine National Anthem. Thank you very much. You may now be seated. Welcome to the 11th PSMID Pfizer Interactive Consensus Meeting. And now, please welcome the President of the Philippine Society for Microbiology and Infectious Diseases, Dr. Mario Panaligan.
Morning. Indeed, it's actually a great event tonight, this morning, as we have our 11th PPRISM, the PSMID Pfizer Anti-Infectives Interactive Consensus Meeting. Definitely, this has been a valuable opportunity for all our fellows in training, as well as our colleagues in PSMID to learn, because we'll be discussing, or we are discussing, new cases that are interesting, that serve as a learning tool for all of us. And I should say that more than a decade ago, when Dr. Margarita Caico and I thought of coming out with a forum for all our fellows in training to learn, definitely discussing a case that would be quite useful for all of us will also be an important venue to exchange ideas and certainly help each other in terms of the management of all these cases. And then 11 years ago, that was in 2008, Pfizer and PSMID actually made an agreement to continue this this forum for all our fellows in training. And definitely, I'm quite thankful with Pfizer for helping us in sustaining this particular event that we do. Usually, on a quarterly basis before, we'll have inter-hospitals conference wherein one particular hospital would have their own case to be discussed by different fellows, and then at the end of the year during the annual convention we'll have a grand PPRISM wherein all our fellows who are designated to discuss will have the opportunity, of course, to present and be able to analyze and integrate all the clinical and laboratory tools that are available to come out with the diagnosis. And from that time, of course, all of us are really very happy in the outcomes wherein each hospital has this opportunity to win, because this, aside from the camaraderie, aside from the learning, it is also a venue for us to become more analytical and aside from that, be competitive. And I'm happy that Pfizer has put down all those winners in the past 10 years. And definitely, almost all hospitals have won the grand prize every year. And so again, welcome to all. Welcome to this 11th PPRISM. Thank you.
Thank you very much, Dr. Mario Panaligan. And now please welcome Dr. Maffy Tyson to present the grand case protocol, criteria for judging, and introduce the judges.
In behalf of the PPRISM Committee of the Philippine Society of Microbiology and Infectious Disease, we would like to welcome you to our PPRISM. In the committee, we have my co-chair, Dr. Carl Henson, and the other members are Dr. Thea Kahulao, Dr. Rowena Virey, Dr. Lara Torno, and Dr. Olaso. And so welcome. So now here are the slides. So welcome to PPRISM, everyone. So I'd like to, before I give you the criteria and the mechanics, I'd like to give you some inputs on what we did for the whole year. So we introduced new innovations. Now for this year, if you remember, previously in the past, we always do this monthly, wherein one hospital presents a case and the other 5 will discuss the same case. So what we did this year in 2018 was recognize the hierarchy of cognitive work. And being fellows in our own institution, we should already be at the highest point of the hierarchy. So in order to gauge the capacity of our fellows to undergo or to see or look at the case through evaluation, synthesis, and analysis, we introduced the TBL, or what we call the team-based learning. So what we did here was give the case to our groups, and individually they will study on their own. What is the differential diagnosis? What are the diagnostics? How are they going to manage the patient? And after that, we mix and match them. The objective there was so that they will be able to develop camaraderie and at the same time know how to work together as a team. So we announced their groupings about 2 days prior to their actual presentation. And then we on the day itself, we give them about 2 hours to meet and then analyze the case together and then decide upon who will be their presenter. And then they present it. Another innovation was that it's interactive in nature. It means that after every presentation, anybody can ask questions. They can even have a debate if they want to. And so these are our fellows, and we're happy to say that it's a quite fruitful endeavor, and they really learned a lot from it. And in fact, they said that this is a good way or a good process in order for them to learn. So I believe we can recommend this to the future PRISM committee to continue with this kind of TBL learning. Now, another innovation that we did today for the Grant PPRISM, unlike in the past, wherein prior to this Grant PPRISM conference, initially, in the past, we meet all the institutions, and then they can ask the questions together, and then we provide them with the answer. The disadvantage was that you cannot gauge who among the institutions are really thinking and really are coming up with a rational question so that they can come up with their final clinical impression. So what we did this year was we requested for clinicians and academicians to evaluate the questions of each institution individually sent to me through email, and I answered them individually too. So it means that, the good thing about that is when they present now, you will notice who were able to ask the most rational and the most relevant questions, because it means that they will be able to discuss the case. So that will comprise 10 points of the final grade, okay? So for the criteria of judging, as I've discussed earlier, the relevance of the questions asked, which is pre-evaluated by Dr. Medi Sanyal, Dr. Vic Hurao, Dr. Thea Kahulao, and Dr. Cherry Abu, will already comprise 10 points. So the presentation now will comprise 90 points of the final score. 30 points will go to case analysis and data integration, 20% to differential diagnosis, 25% to the actual presentation, the content and the organization, 5 to the visual aids quality, 5 their ability to answer questions, and only 5 points for their primary clinical impression. So the presentation proper, they will be given 7 minutes, and the question and answer coming from our judges, 3 minutes. So we have here our Grant PPRISM judges, and they will be introduced properly later on in the course. So may I ask my colleague, the co-chair of the PPRISM committee, Dr. Carl Hinson, to already present the case. So the case that you are going to listen to now already contained all the answers to the questions of our fellows. So we incorporated already the answers, okay? So good day.
All right. I prefer to hold the mic. All right, so let me start with the case. We are presented with a 73-year-old gentleman from Malate, Manila, who is married, Roman Catholic Filipino. He does not live in a nursing home or a long-term care facility and is a retired businessman. The new information is indicated in red ink. In January of this year, he presented with progressive shortness of breath, chest heaviness, and he consulted his cardiologist and he was admitted. He was diagnosed with severe aortic stenosis and 2-vessel coronary artery disease and was scheduled for elective surgery. Give me 1 second. This is kulang. All right. Past medical history includes hypertension, diabetes. Give me 1 second. All right, so let me get back to the case. The past medical history is positive for hypertension, diabetes, and he's known to have aortic stenosis, has been following with a cardiologist for this. He has had no other previous surgeries, no history of malignancy, and no prior history of infective endocarditis. Family history is positive for hypertension and diabetes. He is a non-smoker, non-alcoholic beverage drinker, and reports no illicit drug use, no history of travel or pets, and is not fond of eating in restaurants. Review of system is unremarkable except for undocumented weight loss, no history of melena. Physical examination, the vital signs were normal except for temperature of 38.7 degrees Celsius. He did not have dental caries on oral examination. There was no cervical or other palpable lymphadenopathy. The cardiac examination showed an apex beat at the 5th left intercostal space at the anterior axillary line with no heaves or thrills. He had a grade 3/6 mid-systolic murmur. There was symmetrical chest expansion with clear breath sounds around this time. He had a normal abdomen, no organomegaly. Genital and rectal examinations were not done on admission. There was full and equal pulses, no other skin lesions, and the neurological exam was normal. All right, so he was admitted on the 31st of May. Blood cultures at the time, after 24 hours, was negative. And he was started on empiric vancomycin and gentamicin. His HbA1c was 5.4, and a TEE was done kasi kulang yung history eh. So basically, at the beginning, let me just go back and explain this case. All right, so in January, he had progressive shortness of breath, right? And he consulted his cardiologist. He underwent elective surgery. He had the replacement of the aortic valve with coronary artery bypass grafting. That was done around February of 2018. Post-operatively, he did well, and he was sent home without any problems. Sometime around May of 2018, he developed shortness of breath again, and he was found to have a paravalvular leak and endocarditis, and he was started on some antibiotics and then sent home. And then this was the admission in May. All right, so when he was admitted, blood cultures initially were negative, and the ID service at the time started vancomycin and gentamicin. He had diabetes, but it was under control. The TEE at this time, so he already had a prosthetic valve, and the TEE at this time showed dehiscence of the aortic prosthetic valve with a small perivalvular leak and a small vegetation on the area of the dehiscence. A PICC line was inserted on the 4th hospital day because they were already anticipating a long course of antibiotic therapy. Around June the 8th, he developed acute kidney injury because of the antibiotics, but he did not proceed to hemodialysis. The initial serum creatinine was 0.85. On admission, it rose to 2.11 milligrams per deciliter. Urinalysis was +1 protein, +2 glucose. At around this time, the blood cultures were noted to be positive after 79.2, 77.5, and 81.6 hours of incubation. We will reveal the gram stain of that blood later on. The ID service at this time revised the antibiotic. On a couple of days later, on the 12th hospital day, repeat blood cultures done on the day that the first blood culture turned positive came out to be positive after 4.09 and 4.25 days of incubation. The patient clinically improved on the revised antibiotic regimen, and repeat blood cultures were initially shown to be negative, so the patient was discharged on IV antibiotics. In August of 2018, so he was started on antibiotics, and the plan was for 6 weeks. But in August of 2018, he had recurrence of progressive exertional shortness of breath with orthopnea, and he was readmitted. He was found to have a pleural effusion, which resolved with diuresis. There was no thoracentesis done. A 2D echo done at this time showed that the prosthetic aortic valve was dehisced and with a paravalvular leak. The procedure, they planned to do a redo aortic valve replacement and intraoperative TEE. The old valve and some tissue were excised, and the patient was discharged on outpatient therapy. He had good compliance at home. They had hired a 24-hour private duty nurse. So these were the diagnostics on the entire stay in the hospital. You will note that the patient did not have leukocytosis. Platelets were bordering on low normal, and we did not reveal the cultures to the participants. This was the 2D echo result. This was in June of 2018. It showed a bioprosthetic stented aortic prosthesis that was stable, not rocking. Mean pressure gradient of 22.8 with mild paravalvular regurgitation. There was a structurally normal other valves. In July of 2018, it showed the bioprosthetic aortic valve dehiscence with a small vegetation and severe paravalvular leak. There was no transvalvular leak, and structurally normal 3 other valves. The July 2018 showed the same, and then during the surgery, they did a pre-AVR transesophageal echo, which showed AV dehiscence with a severe paravalvular leak with noted increase in size of the vegetation at the site of the dehiscence. There was good LV function at this time. Some of the other diagnostics, so the reason why the participants or the institutions asked about thoracentesis was because the patient developed pleural effusion during the 3rd admission in August, which resolved, as we said, with diuresis. All right, I think, however unclear that was, I think we were very clear with the participants, and we'll start with the presentations at this time.
Thank Thank you very much, dear doctors. We will now give each institution 7 minutes to discuss the case, and after that, we will give the judges 3 minutes to ask their questions. Good luck to all our presenters. Our first presenter is Dr. Noreen Matiga.
Good morning, everybody. This is a case of a 73-year-old diabetic and hypertensive male who had undergone aortic valve replacement and CABG of 2 vessels after being diagnosed with severe aortic stenosis and coronary artery disease 7 months prior to admission. Within the next 6 months post-surgery, patient had repeated hospitalizations for community-acquired pneumonia, prostatic valve infections secondary to a bloodstream infection, and a redo of aortic valve replacement to which he had received multiple antibiotics. Based on the modified Duke criteria, which defines suspect cases of prostatic valve endocarditis, this patient fulfilled the following criteria. 1 major criteria, which is evidence of endocardial involvement, and these are abscess, new partial dehiscence of prostatic valve, new valvular regurgitation. He also fulfilled 2 minor criteria, which is fever and a predisposing heart condition. Prostatic valve endocarditis is a well-recognized complication of valve replacement repair, and microbiology depends on the following. First is time period between prostatic valve replacement and the manifestation of endocarditis, early versus late, and second is the site of acquisition, community versus healthcare associated. Our patient's course of illness occurred within 1 year of valve surgery, hence classified as early onset, and was acquired perioperatively with infection involving the junction between the sewing ring and annulus, leading to a paravalvular abscess and dehiscence. Microbiology of prostatic valve endocarditis would include the following, with Staphylococcus aureus as the most common causative agent. Diphtheroids cause severe infections in patients with hematologic malignancies and profound neutropenia. Skin findings likewise is common in this infection, which is not present in our patient, thus ruled out. Fungal endocarditis is rare, with low survival rates of less than 20%, despite aggressive medical and surgical interventions. It is characterized by large bulky vegetations with frequent embolic events among IV drug abusers and immunocompromised patients. These are not congruent with our patient, hence excluded. For non-Hasek gram-negative aerobic bacilli, factors present in this patient that may place him at risk for developing IE is demonstration of healthcare contact and associated with prostatic valves and implanted endovascular devices. Common in gram-negative IE is the persistence of bacteremia, even with high levels of antimicrobial activity and occurrence of major embolic phenomenon, bacteremic relapses, and rapidly progressive congestive heart failure. This, however, is not the course of illness of our patient, hence ruled out. Before we proceed with microbial differentials, let us review the clinical course of this patient. He had undergone a highly invasive cardiac procedure 6 months prior to admission, where the intraoperative procedure lasted for 8 hours. Spectrum of disease process of IE started with direct microbial contamination at the time of surgery. After bacterial seeding of the endocardium, erosions into various cardiac structures took place through an interplay of direct bacterial invasion, enhanced inflammatory response, and liquefactive enzyme release within cardiac tissues. Aortic valve is especially prone to this process, probably due to a much less annular fibrous tissue support in the aortic position. Looking closely at the clinical progress of our patient, he developed undefined febrile illness with nonspecific constitutional symptoms 3 months post-aortic valve replacement. He responded initially to empiric antimicrobial therapy, but had recurrence of fever after completion of antibiotics for another disease. This may be the actual time of onset of bacteremia coming from an ongoing infection of the cusp of the bioprosthetic aortic valves. Blood culture at this time, however, failed to isolate any organisms because of low-level bacteremia, usually representing 1 to 100 bacteria per ml blood in IE. A biofilm formation on the surface of these biomaterials allows less susceptibility to the host immune system and development of persisters or dormant cells. There was eventually clearance of bacteremia after completion of antibiotics for prostatic valve endocarditis. However, progressive dyspnea was noted, and this signifies the presence of uncontrolled source of infection, in this case, an extension of infection to the perivalvular area. There was paradoxical progression of tissue destruction with enlarging vegetations at the site of decins, despite completion of PVE antimicrobial regimen. Volume overload on the ventricles resulted, eventually leading to congestive heart failure. Hematologic picture also reflected the severity of this destructive process. Anemia in this patient is associated with intravascular hemolysis secondary to paravalvular leaks. Regurgitation of blood flow or jet from the paravalvular leak or subvalvular stenosis is the underlying mechanism for hemolysis. This patient's poor WBC response to this severe infection reflects his immunosuppressed state brought about by poorly controlled diabetes, which causes an abnormal cell-mediated response. The normal HbA1c of this patient could not accurately reflect the true value of blood sugar control because of low hemoglobin levels at the time of evaluation. There was also a spillage of glucose into the urine. Perivalvular extension is commonly associated with necrotizing organisms and directly proportional to their virulence. Staphylococcus aureus and coagulase-negative staphylococci, or CONS, are the most common culprit of prostatic valve endocarditis. Both staph species possess immune evasion strategies to cause persistence and recurrent infections. Staph aureus does this by internalizing into intact endothelial cells, while staph epidermidis does it by adhering and forming biofilm on surface of biomaterials. In this patient, there was prolonged undefined illness before IE diagnosis was made. Con species, specifically staph epidermidis, is compatible with this patient's clinical course. This is not compatible with clinical course of staph aureus, which presents acute septic syndrome and tissue destruction in a short period of time. When the source of infection of this patient was completely addressed through surgical removal of the infected sites after a redo aortic valve replacement, the patient's condition improved and he was discharged eventually. For a final diagnosis, complicated prostatic valve endocarditis, coagulase-negative staphylococci, probably Staphylococcus epidermidis, status post-aortic valve replacement, bioprosthetic, and CABG, status post-redo aortic valve replacement, bioprosthetic, severe aortic stenosis, and coronary artery disease, 2-vessel, diabetes mellitus type 2, poorly controlled, and hypertensive atherosclerotic disease. Thank you.
All right. One question. Why do you think this is staph if it did not grow within 4 days of blood culture? Usually staph grows really quickly, usually within several hours after blood cultures. This syndrome grew at least 80 hours after the initial culture. That's very atypical for staph aureus.
Okay. For staph, the blood culture result would also depend on how much blood you took, because we have to take at least 10 ml of blood, especially if there is low inoculum on the blood. So that is why we have to take repeated blood cultures, and the amount of the blood should be adequate.
Sure, but then all cultures appear to grow, all sets, which means it's a high inoculum. It's just basically is a slow-growing organism. That's probably a key when you make your differential diagnosis. And if it's a slow-growing organism, that basically rules out Staphylococcus.
My question is, so your main differential for the pathogen is a coag-negative staph?
Yes.
Maybe can you expand that a bit? Like what other coag-negative staph and why you kind of just zeroed in into staph epi?
We zeroed in on staph epidermidis because compared to the other coagulase-negative Staphylococcus, it is the most common cause of hospital-acquired infection, especially with devices, hospital devices like prosthetic valves, central lines, and because it is a normal commensal of the skin, so usually it is one of the most common causes of hospital-acquired infections in patients with who underwent device-related infections.
All right. Well, I guess you're right that basically intermediate onset prostatic valve endocarditis is predominantly Staph aureus, Staph epi. The only thing that didn't fit is the growth rate, and that's basically, I think, bifurcation in your differential diagnosis, wherein if it's not growing as you'd expect, you should think of something else. Is what I think that's what we have from the audience, from the judges.
Thank you very much, judges. And to our first presenter, Dr. Noreen Matiga. Before we proceed to our next presenter, we'd like to welcome back on stage Dr. Carl Hansen.
All right, sorry to be makulit, but the presenters, the institutions, they received the correct protocol. I just want to assure you all of that. And the judges also have the correct protocol. But for the sake of those following us along and got a very unclear picture of the case, let me just present the complete slides. There was one slide that was missing that was pretty crucial when I first presented it. Like our patient who had a redo surgery. All right, 73-year-old gentleman from Malate, Manila, retired businessman, January of 2018, progressive shortness of breath and chest heaviness. He's known to have severe AS, consulted a cardiologist, and was found to have severe AS and 2-vessel CAD, so he went ahead and did the elective surgery. In early February of 2018, he had an aortic valve replacement and a coronary artery bypass grafting, 2 vessels. The post-operative course was unremarkable. There was no microbiology done on the tissues. He was doing well until May of 2018 when he developed generalized weakness, anorexia, and fever for about 2 weeks before being admitted at another private hospital where he was treated as a case of community-acquired pneumonia. He was given about 5 days of meropenem and then 3 days of oral cefixime. So he was discharged. They thought he was better, but then a couple of days after discharge, the fever recurred. So he went back to his doctor, his cardiologist, who admitted him to the institution. At the time, the cardiologist was already thinking about infective endocarditis. So on admission, they did blood cultures, which was initially negative after 24 hours. He was started on empiric vancomycin and gentamicin. And then on June the 8th, he had acute kidney injury, and then he had a positive blood culture. They revised the antibiotic regimen, and then there was some clinical improvement. On June the 13th, the blood cultures were still positive. They continued the antibiotic regimen because the patient was slowly getting better. And then eventually the blood cultures returned negative and he was discharged. However, while he was receiving outpatient antibiotic therapy, he had recurrence of progressive exertional shortness of breath in August of 2018. So he was readmitted, and at this time, the 2D echo showed a prosthetic valve that was dehisced with a paravalvular leak. They did surgery again, submitted the tissue for cultures and workup, and then they did continue the same antimicrobials post redo surgery. Okay, I think that's my last slide, just to clarify the case for those who did not receive a case protocol.
Carl,
Yes,
can we
sir.
ask for clarification? So the blood cultures were obtained May 31st.
Yes, sir.
And
On
then-
admission.
On admission.
Yes.
It was reported on June 8th.
Yes.
But it grew after 80 hours?
Yes, that was a little. So when we looked at the chart, sir, the blood cultures were reported. Critical value, blood cultures positive on June the 8th, but the lab reported it as being positive after 70 plus hours, 70 to 80 hours. So there was a discrepancy of a couple of days, which I think they spent on workup of that positive. And you'll find out later, I guess everyone else will find out later why it took so long to be reported. All right? Thank you very much. We'll have the second presenter.
Thank you very much, Dr. Carl Hansen. And now let us move on to our second presenter. Please welcome on stage Dr. Maris Nepomuceno.
Good morning. We are given a case of a 73-year-old male who had a 2-week history of generalized body weakness, anorexia, and fever 3 months after undergoing CABG and bioprosthetic AVR. He was diagnosed with community-acquired pneumonia based on these symptoms despite the absence of cough. He was empirically treated with meropenem with fever recurrence just 2 days after discharge. The only pertinent findings on PE were high-grade fever and a grade 3/6 mid-systolic murmur. CBC results were unremarkable. Chest X-ray showed pulmonary congestion. TEE showed bioprosthetic valvular dehiscence, a severe paravalvular leak, and a small vegetation. Blood cultures had delayed positivity. Given all these, he fulfills at least 2 major and 2 minor criteria based on the modified Duke criteria, and my initial impression is a definite prosthetic aortic valve endocarditis. Let us first understand what happened to our patient. In terms of timing, the patient falls under the category of early onset PVE. During CABG with AVR, the pathogen could be acquired through direct contamination intraoperatively or through hematogenous seeding during the immediate postoperative period. In the early post-implantation period, the prosthetic valve and the paravalvular tissues lack endothelial lining, making them vulnerable to microbial invasion and infection. Infection at this time, especially with a virulent pathogen, leads to complications including perivalvular abscess formation and, as seen in our patient, valvular dehiscence and paravalvular leak. Clinical presentation of PVE is variable. In our case, nonspecific constitutional symptoms including generalized body weakness, anorexia, and fever are present due to cytokine production. Symptoms and signs of heart failure including progressive dyspnea, orthopnea, and chest X-ray findings of pulmonary congestion are due to the aortic valve dysfunction. With the administration of appropriate antibiotics, the bacterial load is decreased, eventually leading to both clinical and microbiological response. However, microorganisms have the ability to survive and grow within vegetations. One of the most important mechanisms is biofilm formation. Bacteria in the biofilm are less susceptible to the host defense system and to antimicrobial agents due to the protection of the polymeric matrix and the switch to a more quiescent state. Hence, with inadequate treatment or poor source control, relapse of symptoms and progression of complications may occur. After understanding the events that led to the patient's PVE, let us try to identify the culprit. We made the diagnosis of early onset PVE based on several factors as previously discussed. Additional information worth noting are the absence in the history of dental or urologic procedures and travel or pet exposure, and absence of a clinical response to vancomycin and gentamicin. Weekly monitoring of blood cultures may be an important clue. The most common etiologic agents of early onset PVE are Staphylococcus aureus, coagulase negative Staphylococcus, nosocomial aerobic gram-negative bacilli, fungi, and diphtheroids. Staphylococcus aureus, the most common pathogen of PVE, is virulent and although usually associated with smaller vegetations, is known to cause significant tissue destruction in a short period of time. Coagulase negative Staphylococcus, most commonly Staph epidermidis, similar to Staph aureus, is also associated with significant tissue destruction. Aerobic gram-negative bacilli, on the other hand, are associated with larger vegetations. Risk factors as enumerated in the slide were not present in our case. Fungal PVE is most commonly due to Candida species. It is associated with large, dense vegetations, and additional risk factors were not elicited in our case. The temporary response to meropenem cannot be explained by a fungal etiology, making this differential less likely as well. The administration of meropenem could explain the delayed blood culture positivity. However, the patient had a negative blood culture prior to antibiotics during his admission for CAP, which makes this assumption less likely. Staphylococcus aureus, coagulase negative staph, and nosocomial gram-negative bacilli are organisms expected to be isolated routinely without need for extended incubation. This leads us to infer that a slow-growing or a fastidious organism is the culprit. The HASEC or fastidious gram-negative bacteria that frequently colonize the oropharynx. Detection in blood cultures is usually within 3 to 5 days. Dental manipulation, a common source of infection in this group, was not present in our case. Due to its low virulence, endocarditis tends to be subacute in nature, and patients tend to have larger vegetations at diagnosis. It is more likely to be community-acquired and is typically late-onset PVE. Among the non-tuberculous mycobacteria, rapid growers are most associated with PVE. Contamination of the surgical site at the time of operation or the implanted prosthetic material, along with intravenous catheter-related bacteremia, are the proposed modes of infection. Due to their vegetative nature, presentation of symptoms occurs late in most cases, which is inconsistent with our case. Among the slow-growing organisms, the diphtheroids are often associated with early-onset PVE. Propionibacterium acnes is found in normal skin flora. Infection may originate from bacterial seeding at the time of surgery, as it is the predominant organism in the chest. There is a male predilection for P. acnes PVE. Median time to blood culture positivity for these organisms is 7 days. In a recent case series, the time from valve implantation to diagnosis of IE was at 4 months to 12 years, with fevers, chills, and malaise as the most common symptoms. Advanced disease at presentation with valvular dehiscence, regurgitation, or absence is common. Vegetations larger than 1 centimeter are less common. Although vancomycin is considered acceptable antimicrobial therapy for P. acnes, the absence of clinical response in our case could be attributed to the presence of a biofilm, which is considered a major virulence factor of P. acnes. Recent studies have shown that the biofilm eradication concentration of vancomycin needed to kill P. acnes was greater than 100 micrograms per ml. Addition of rifampin in the regimen could have improved clinical response. My final diagnosis is early onset prosthetic aortic valve endocarditis secondary to Propionibacterium acnes. Thank you.
Thank you very much. And now questions from our judges.
So yeah, that was a great presentation. P. acnes could typically act like this. The thing that doesn't fit, it doesn't recur that quickly once you stop the antimicrobial therapy. So the question I have is, what would you have done differently during the initial diagnosis in May or early June?
In early June, sir. I think the antimicrobial therapy, maybe the patient could have benefited with early addition of rifampin, since it's also in the recommendations for prosthetic valve endocarditis. And also, I'm also not sure why surgery was not done early on in the course.
You have other differential diagnosis aside from propionobacterium, but you mentioned, you discussed a lot about the non-effect of vancomycin, but on your final impression, but you didn't say that to your other differential.
Oh.
Can you, maybe now you can expand that?
So for my other differentials, my thought process here was the organism should have responded to meropenem also, because it seems like the symptoms that they treated for CAP was already part of the endocarditis. So actually that's why I already ruled out a fungal etiology and NTM. So we were also thinking, if this was staph, why wasn't it responding to vancomycin, if it was coagulase negative staph? So our thinking was maybe it was because of the biofilm. The aerobic gram-negative bacilli, I think, should have responded to gentamicin as well. I'm sorry, did I answer your question, po?
Yeah, the one I was alluding to is basically early surgery. Cardiac surgical consultation whenever there is question of perivalvular leak, or actually any situation wherein you consider prosthetic valve endocarditis, you have to get your cardiac surgeon on board right away. All right, that's what we have. Thank you.
Thank you very much, judges, and Dr. Maris Nepomuceno. Let us now have our third presenter, Dr. Sheena Marie Ann Santos.
Good morning, doctors. I'm Sheena Santos, and I'll be presenting our insights in this case. For our salient features, we are presented with a 73-year-old male, hypertensive and diabetic, who in February 2018 underwent bioprosthetic valve replacement for severe aortic stenosis. This patient, 3 months post-op, presented with non-specific constitutional symptoms and was treated with meropenem for 2 weeks as a case of community-acquired pneumonia. Fever lies, and he was subsequently discharged. This same patient, after 48 hours, was readmitted for fever recurrence and with positive blood cultures, both of which persisted despite vancomycin and gentamicin therapy. A transthoracic echo was done, which was non-contributory, but due to the high index of suspicion, a transesophageal echo was done as well, which revealed bioprosthetic valve dehiscence with small vegetation and severe paravalvular leak. Prosthetic valve endocarditis has classically been classified on the basis of time period between surgery and the manifestation of endocarditis. It would be important to classify PVE, as the microbiology of early and late onset PVE are different. In general, PVE occurs secondary to direct contamination of prosthetic valve and may be due to secondary hematogenous seeding from a distant site. In early PVE, endocarditis happening less than 1 year post-surgery, the perivalvular tissues are vulnerable to the secondary microbial seeding because still lacks the protective endothelial lining. Infection is believed to have been acquired intraoperatively or in the immediate post-operative period. I have listed here the most common pathogens in early PVE, which include Staph aureus, cons, diphtheroids, gram-negative bacilli, and fungi. And the organisms that cause late onset PVE or those happening more than 1 year post-op as listed below. So our patient fell under the less than 1 year post-operative period placing him under the early onset prosthetic valve endocarditis. What do we think happened to this patient? In February 2018, our patient underwent bioprosthetic valve replacement for aortic stenosis, the foreign body putting him at risk for infection via the direct microbial contamination or hematogenous seeding from a distant infectious site. As discussed earlier, early post-op, the valve still lacks the endothelial lining that would protect the patient from bacterial adhesion and infection. So our patient 3 months post-op developed constitutional signs and symptoms in which we theorize he became bacteremic, secondary to a pulmonary source of infection. Given that this patient's fever, lice, and he clinically improved on the next 2 weeks on meropenem, shows that the etiologic agent is sensitive to the said drug and is likely caused by a community-acquired infection, such as pneumonia. 48 hours off antibiotics, this patient's fever rapidly recurred, likely because during this time, the bacteria has already seeded into the prosthetic valve and caused infective endocarditis. The non-response to vancomycin and gentamicin, reflected by his persistent fever and bacteremia, suggests that the etiologic agent is susceptible to neither of the two drugs. With the suspicion of IE in mind, a negative transthoracic echo is not enough to completely exclude the diagnosis. Given a high index of suspicion, a transesophageal echo was performed. True enough, TEE revealed findings compatible with prosthetic valve endocarditis. On our readings, suggest that the etiologic agent may be gram-negative, hence the non-response to vancomycin, and likely lacks susceptibility to gentamicin. However, the question still remains, what organism caused this PVE? The list of possible organisms for early prosthetic valve endocarditis is very broad, but can be narrowed down by the patient's presentation, clinical course, and findings in literature. Our patient was empirically treated with meropenem, which is a broad-spectrum antibiotic, and he improved. 48 hours of antibiotics, the symptoms recurred, and despite vancomycin and gentamicin therapy, which covers for most of the pathogenic gram-positive and selected gram-negative organisms, continued to be febrile. Based on this analysis, we have excluded the possibility of Staphylococcus aureus, which may also be present with an acutely ill patient, which will likely follow a fulminant course. So patient has no other major risk factors such as central lines prior to the presentation, and prior to the admission, only had prophylactic antibiotic therapy pre-op and meropenem as treatment for the pneumonia. Cons, which may though present as indolent and progress over 30 days to 1 year, often requires cardiac surgery. Diphtheria is a rare cause of endocarditis. All three organisms should have responded to vancomycin, so we've ruled them out. Finally, fungal endocarditis has been ruled out as this will not respond to antibiotics and has a very fulminant course and a high mortality. This infection often happens to severely immunocompromised patients. Our patient, other than his controlled diabetes, has no other risk factors. Gram-negative bacilli, we are left with the gram-negative bacilli, which can be further subdivided into the HASEC and the non-HASEC group, which has quickly been, the non-HASEC group has been quickly eliminated by its fulminant course. It's often healthcare-associated, rare, and often fatal. They comprise approximately 1.8% of infective endocarditis. We have to take note that the patient's symptoms presented 12 weeks post-operatively, wherein he most likely acquired an infection from the community. This is an important statement as microbes from the hospital differ from those of the community. HASEC significantly associated with prosthetic valve endocarditis and has a better prognosis. To further narrow down the differentials, I have listed the organisms stated by the 2016 Community-Acquired Pneumonia Guidelines to discuss the presence of possible organisms that could have caused a patient's pneumonia. So it has been listed that chlamydia, mycoplasma, moraxella, Haemophilus, and enteric gram-negative bacilli can be cultured. However, enteric gram-negative bacilli, though a possible cause of pneumonia and endocarditis, most present in patients with unstable comorbid conditions. Chlamydia, mycoplasma, and moraxella cannot be grown on routine blood cultures and would often require PCR for identification. Haemophilus is a common cause of CAP and is fastigious and may take a while to grow on culture media and requires some select environmental conditions to cultivate. Not surprisingly, it may take longer for it to be identified and grown in a laboratory. It is a rare cause of endocarditis, approximately 0.8 to 1.3%. follows a subacute course. The most common would be Haemophilus parainfluenzae, and patients would often present with a history of respiratory tract infection in 2.5% of cases. So, our final diagnosis is prosthetic valve endocarditis on an aortic valve, likely from Haemophilus species. Thank you.
And now let's have our judges for their questions.
So you think the admission in May 2018 is community-acquired pneumonia? It's not. They didn't have endocarditis then.
I think that during this time, the patient had community-acquired pneumonia and developed bacteremia, for which put him at risk for infective endocarditis.
I still go back to my first comment earlier. Haemophilus will grow, usually not that late. So.
The blood culture turned out positive after 70 plus hours po, doctor.
Do you expect that as the growth characteristic of Haemophilus influenza?
Given that the patient has previously been antibiotic therapy, the low bacterial load could have caused the delay in the growth in the culture.
Then again, if you say low bacterial growth, it looks like all the cultures that were obtained on admission are positive, which means that it's not really low, it's a high burden disease.
Given that Haemophilus as well is a fastidious organism po, doctor, the delay in the growth could be explained by the characteristics of the microbe.
Okay, well, thank you.
Thank you po.
Thank you very much, judges. And our presenter, Dr. Sheena Marie-Ann Santos. Let us now welcome our fourth presenter on stage, Dr. Diana Gonzaga Ramos.
We are presented with a case of a 73-year-old male from Malate, Manila, who underwent an elective aortic valve replacement and subsequently developed 2 consecutive episodes of prosthetic valve endocarditis 3 months and 6 months post-operatively. According to Rivas and Glaser et al., the etiology of prosthetic valve endocarditis, or PVE, can be divided into early and late onset. Our case presented within 1 year of surgery, thus termed as early onset PVE. What organism could have possibly caused the patient's prosthetic valve endocarditis? Since 1996, several studies aim to identify the different causes of early onset PVE. In summary, the 5 leading causes are Staphylococcus aureus, coagulase negative Staphylococcus, Streptococcus viridans, Enterococcus, and Hasek bacteria. Other causes include non-Hasek gram-negative bacteria, fungal infections, and culture-negative endocarditis. Our patient, having presented with a positive blood culture on the 8th day of incubation and subsequent positive blood culture on the 4th day, we can safely rule out culture negatives. Fungal PVE can also be ruled out due to the rarity of this etiology and absence of an embolic event and large fungal mass around the vegetation, which are typical findings. The remaining organisms would be as follows: your Staphylococcus aureus, the cons, Enterococcus, Streptococcus viridans, Hasek, and non-Hasek bacteria. Staphylococcus aureus, though the most common cause of PVE, may not be a possible etiology for this case. This is due to the lack of embolic events and large destructive valve lesions early in the patient's course of illness. The same is true for the coagulase negative Staphylococcus, which also typically presents with early valve destruction and heart failure symptoms with or without intracardiac abscess. The following less virulent organisms can all cause a subacute PVE, all of which can also cause relapse endocarditis. So, which is the possible etiology? Non-Hasek gram-negative bacteria, E. coli being the most common, can present in the elderly and diabetics. However, this group of bacteria rarely cause relapse, with only one reported case in a female patient with pulmonary sarcoidosis as a risk factor, which is absent in our case. Hasek endocarditis, on the other hand, is a frequent colonizer of the oropharynx, exhibiting slow growth in culture media and prolonged clinical course. However, just like the non-Hasek, it also has only one reported case of relapse with a predisposition from chronic dental infection, which is also absent in our case. Streptococcus viridans also presents as lower and milder valve destruction. However, it typically presents with a large vegetation at the onset, unlike our patient. And just like the others, it only has one reported case of relapse. Enterococcus, most commonly Enterococcus faecalis, presents the typical course of our patient, an elderly male with subacute onset of fever, systolic murmur, generalized body weakness with weight loss with an affectation of the aortic valve. Though this bacteria is only third of the leading causes of PVE in the Philippines, according to the unpublished data of Philippine Heart Center in their 10-year retrospective study, Enterococcus still continues to be reported as a common cause of relapse endocarditis worldwide. Throughout history, there have been 6 studies stating multiple relapse of enterococcal infection since 1954. Today, there are already 19 reported cases of relapse with Enterococcus faecalis and 10 cases for Enterococcus faecium. Enterococcus is a relatively non-virulent gram-positive bacteria which is a part of the normal gastrointestinal flora. McCormick et al. In 2000 stated that enterococcal endocarditis typically affects the aortic valves during transient bacteremia. Typical source is the genitourinary or abdominal tract. It typically infects men older than 60 years old, such as in our case. It may also infect women of childbearing age. So how did the patient develop endocarditis? The patient's history of surgery, prior use of broad-spectrum antibiotic, which is meropenem, may have precipitated this infection. Having had bypass surgery, we hypothesize that this patient could have had indwelling catheters and central lines during his first admission, which could have promoted mucosal disruption. In addition, the use of broad-spectrum antibiotic promoted bacterial overgrowth in the gut, causing this enterococcite to translocate intact epithelium, traverse the epithelial barrier by phagocytosis, and migrate in the phagocytes. The 7 known virulence factors for enterococcus further contributes to the collagen adhesion around aortic valves. The pili present in gram-positive bacteria further promotes this adhesion and biofilm formation around the prosthetic valves. Recurrences appear when the risk factors persist or recur, as such in our case, due to the presence of PICC line for IV antibiotic at home, which promoted the recurrence of endocarditis. Relapse is common with this organism due to low virulence of this strain, likely living in a dormant state, which is easily triggered in the persistence of risk factors. Treatment of this infection necessitates prolonged antimicrobial therapy and closer surveillance of parameters and other sources of enterococcal overgrowth, such as your colon, in order to detect a relapse. So our final diagnosis for this case is recurrent prosthetic valve endocarditis, probably secondary to enterococcus faecalis, aortic stenosis, coronary artery disease, status post-coronary artery bypass graft, status post-aortic valve replacement, status post-redo aortic valve replacement. And here are my references. Thank you and good morning.
Thank you very much. And now let's have some questions from our judges.
So this patient received vancomycin and gentamicin empirically.
Yes,
so
doctor.
that's the treatment for Enterococcus faecalis. Why do you think it didn't work?
According to studies, there have been many cases of vancomycin-resistant enterococcus, especially if these patients have received prior antibiotics. And enterococcus mainly can have mutations that can promote virulence factors and further resistance to your vancomycin.
That's usually Enterococcus faecium, not faecalis.
Actually, Doctor, across studies, there have been more data on Enterococcus faecalis recurrence and endocarditis, and some studies on Enterococcus faecium.
Do you have data on the vancomycin-resistant enterococcus in your institutions in the Philippines to back your claim?
Not necessarily in the Philippines, Doctor, but across worldwide, the data that I presented.
Thank you.
Thank you.
Thank you very much, judges, and to our presenter. And now, please welcome our fifth presenter, Dr. Mark Peralta.
Hello. Good morning. These are the salient features. Given the history, PE, echo findings, and persistently positive blood cultures, prosthetic valve endocarditis is entertained, as the patient fulfilled two major clinical Dukes criteria. PVE has been categorized as early onset and late onset. As the patient had clinical manifestations within 3 months from the time of prosthetic valve surgery, his condition falls under early onset. This is important because pathogens in the two categories are different. Siciliano described the most common microorganisms associated from PVE among patients who developed the infection within 3 months post-operatively. Grouping together, the organisms can be categorized into three: gram-positives being the most common, followed by gram-negatives, and fungi. Fungi are rare causes of PVE, comprising of only 6.3 of cases, with Candida and Histoplasma being the most common. Healthcare exposure, antibiotic use in the past 3 months, and diabetes are the risk factors for fungal PVE, which are seen in a patient. Despite the presence of fever and cardiac failure symptoms in the patient, fungal PVE clinical manifestations are often severe, including presence of embolic phenomenon and septic shock, which were not observed in the patient. Multiple journals have reported characteristic large, dense vegetations of fungal PVE ranging from 14 to 22 millimeter at the time of diagnosis, mainly affecting the aortic valve in 72%. Other findings are as follows. Due to rarity of this organism, coupled by less severe clinical manifestation, a small vegetation at the initial presentation, we do not consider fungal cause. We are left with gram-positive and gram-negative. Staphylococcus, both methicillin-sensitive and resistant, comprise majority of the gram-positive organisms, while the gram-negative can be divided into HASEC versus non-HASEC. Based on epidemiology, HASEC group are rarely implicated in the early PVE and are more commonly seen among native valve IE. The following are risk factors and clinical presentation of gram-positive and gram-negative PVE in general. What is significant between the two are the following. Common clinical foci of infection in gram-positive PVE are catheter-related, surgical site, and pleuropulmonary infections, while secondary source of infection in gram-negative PVE are mainly hematogenous seeding coming from GI and urinary tract. As to the presentation, El Haddad stated that both gram-positive and negatives may cause heart failure symptoms, systemic embolization, and cardiac abscesses. Though in general, systemic manifestations are uncommon in gram-negative PVE. Echocardiographic presentation are as follows. Severe paravalvular complications and abscess formation due to the presence of virulence factors are seen with gram-positive PVE, while gram-negative PVE, like fungal, presents with larger vegetations due to lack of fibrinolysin. Canzoneri showed that persistent bacteremia is more common in gram-positive endocarditis. Munita revealed that the duration of bacteremia after initiation of appropriate antibiotics in gram-positive organisms range between 7 to 20 days, with a mean clearance of 7 days, while the mean duration of gram-negative is 1 to 6 days, with an average of 3 days. Our patient had a probable pulmonary infection with persistent bacteremia, and because there is absence of peripheral manifestations of IE and large vegetations, a gram-positive organism is entertained. Among the gram-positive organism, Streptococcus is the least likely to have the caused early onset PVE, as it is often seen in late onset, almost mimicking the native valve IE. Between the Staphylococcus and Enterococcus group, patients with enterococcal IE were significantly older. Both are nosocomially acquired and common in diabetics. And the presence of central line is more in keeping with Staphylococcus. But he had heart failure symptoms and absence of systemic embolization, which are more compatible with Enterococcus. Likewise, aortic valvular involvement is more common in enterococcal than staphylococcal enterococcus. Therefore, we are considering early onset PVE secondary to enterococcus, probably Enterococcus fecalis, being it the most common causing IE among the enterococcus, with the characteristic adherence factors that are absent in the non-fecalis group. The prosthetic valve and perivalvular tissues are vulnerable for secondary microbial seeding during the early post-implantation period when they still lack protective endothelial lining. In this case, endocarditis may have been a consequence of a secondary hematogenous seeding from a distant focus, probably from the respiratory tract, in the patient diagnosed with pneumonia. Microbial adherence is a critical step in endocarditis and involves complex interaction between microbial and host surface. These processes result in vegetation and biofilm formation. The symptoms of IE can be protein. Fever, which is brought about by the release of pyrogenic cytokines altering the thermoregulatory set point, is a common finding in 96%. Prolonged fever is associated with specific pathogens or presence of complications. Anemia, seen in up to 90% of cases, is brought about by the destruction of RBC due to the turbulence as it passes through the damaged valves, or additionally due to chronic inflammation. Bacteremia is present in more than 90% of the time. However, when antibiotics were administered, like in our case, meropenem may have reduced the bacterial load and delayed the growth of organism in cultures. A probable reason of the patient's initial response with meropenem is the presence of tolerance to beta-lactams among enterococcus, exhibiting only bacteriostatic effect. However, despite empiric antibiotics, we continue to have persistent febrile episodes that will make us consider the following causes. However, signs of embolic complications and other sources of infection are absent, and MDRO are rare and presents with drastic symptoms requiring intervention at the outset. The most plausible explanation is delayed response to antibiotics due to the presence of less susceptible bacteria in the biofilm. Canzonieri pointed out that it takes at least 7 to 10 days of specific antibiotic therapy for temperature to normalize in IE. Pericas showed a fever duration range of 3 to 15 days prior to improvement in enterococcal IE. A change in antibiotic due to renal cause was noted, and clearance of bacteremia happened on the 16th day. However, despite the improvement, patient was readmitted due to heart failure. This is because killed bacteria within vegetations may persist for months after therapy, leading into chronic inflammation, resulting to valvular destruction and complication. Heart failure, seen in almost half of enterococcal IE, requires valve replacement in 41% of cases. Hence our final diagnosis. And our sources. Thank you.
Thank you very much. And now some questions from our judges.
Can you clarify, where did the enterococcus come from, you think?
From the...
So where was the source?
Pneumonia, doc.
How common is enterococcus as a cause of pneumonia?
Given the fact, doc, that this patient is a diabetic, I think the possibility of acquiring infection of other organisms is increased po, doc.
All right. Apparently they have the same questions. Okay. Thank you so much.
Thank you.
Yeah.
Thank you very much to our judges and our fifth presenter. And now, let's have our final presenter for the day, Dr. Erika Joanna Caperonce.
Good morning, everyone. I'm sure by now you memorized already the salient features of the case, so I will move on to my next slide and emphasize the important points of my case later on. So in approaching the patient with fever and heart disease, we can look at the disease syndromes according to the layers of the heart. The major clinical manifestations of pericarditis and myocarditis is usually chest pain, and it usually comes with evidence of myocardial injury. In our patient, there was absence of any increase in cardiac biomarkers or ECG changes. Moreover, in the patient with a predisposing heart condition, a recent prosthetic valve replacement, endocarditis is more important to consider. The presence of vegetation and positive blood cultures also were major features in our case. And in fact, even with the very limited data given to us initially, we can already conclude that the patient fulfills the criteria for definite PVE according to Dukes. In approaching prosthetic valve endocarditis, we first look at the timing of infection. The cutoff point between early and late PVE is 1 year. Pathogenesis, microbiology, and clinical manifestations vary based on this, and the patient falls under early PVE. Next, let me mention the important features that helped me dissect this case. There was valve dehiscence and paravalvular leak at presentation. Despite the chronic course of the patient, he never manifested with any shock, embolic, or stroke complications. Embolic or stroke complications, which tells us that the pathogen is of relatively low virulence. There was also a relapse despite presumably targeted antimicrobial therapy. The organism also grew very late. And to add, the patient did not have any significant environmental exposures, no central lines, dental procedures, instrumentation, or any chronic debilitating illnesses except for well-controlled diabetes. Next in my approach, what are the usual organisms that we consider in early PVE? So the following organisms are implicated. Of note, fungal and gram-negative IEs are usually seen at a lesser extent. The next issue in determining the organism is the time to positivity. Since the major feature highlighted in this case was its prolonged incubation. So standard incubation of 5 days is usually enough to isolate the usual pathogens in IE, including Candida. Some organisms are fastidious and will require special culture media to grow. This table shows us the growth times of bacteria and yeast in blood cultures. Of note, we see that strep, staph, gram-negative bacilli usually grow very early. Candida can reach for about 7 days of incubation until you can isolate it. So, not seen in this table is Cutibacterium acnes, but deserves special mention because sometimes it needs prolonged incubation, sometimes up to 14 days to grow. But since our patient was given meropenem a week prior, does this have a certain effect on the growth time? So this slide will show us that antibiotics significantly can delay blood culture growth but antibiotics can significantly affect the growth time in blood cultures. However, the difference is a matter of hours and not days, making the feature of prolonged positivity a significant clue to the organism. With incidence, salient features, and time to positivity in mind, here are the organisms that I considered. Staph aureus is very common, and the risk factors for infection are written here and are present in our patient. But because of its virulence, staph PVE usually presents within the first month post-operatively and is associated with very high mortality. Patients are also generally more toxic. Coagulase-negative staph is common, and the time to infection is also similar to our patient. However, the organism is also associated with very high mortality second to staph, and heart failure usually presents early, not seen in our patient. It also grows within 15 hours. Streptococci is considered because overall prognosis is favorable, but it is usually more common in late PVE. Usually, there is an evidence of a triggering event, a preceding dental genitourinary procedure, which was absent in our patient. The enterococci PVE is usually described to have sources such as indwelling catheters, GI or UTIs, not present in our patient. Also, there is a high rate of myocardial abscess formation compared to non-enterococcal PVE. E. coli and Pseudomonas are the most common gram-negative organisms in PVE. Our patient was recently admitted, and healthcare contact was a significant risk factor in this organism group. UTI is also a salient feature. However, in this patient, it was absent. So there is also a very high risk of mortality, warranting usually early surgery. So the Hasek organisms have a predilection for the prosthetic valves, and they usually take a longer time to grow. It also has a lesser mortality rate and infrequent heart failure. It fits the clinical profile. However, it usually occurs in patients who are younger and usually present with immunologic phenomena absent in our patient and is associated with dental or GI procedures as predisposing bacteremia, again, absent in our patient. So, fungal PVE, as I showed earlier, Candida grows late. However, these patients are usually more toxic, and they usually imply that the patient had a complicated perioperative course and prior IE and exposure to central venous lines absent in our patient. Nutritionally variant strep, like Abiotrophia defectiva, has a high rate of bacteriologic failure. However, it is involved with very high systemic complications. Cutibacterium acnes, formerly known as Propionibacterium acnes, just the fact that the patient had open chest surgery predisposed him to this organism. Also, it should always be included in new onset paravalvular leak. Treatment failure is very high in this group without surgery due to biofilm formation, mediated resistance. And more importantly, it is a slow-growing bacteria, ranging from about 3 to 9 days with a median of about 7 days. Although rare, I consider this as my likely organism due to the facts that I mentioned earlier. So to correlate and defend this, our patient was exposed to this bacteria because it is a predominant microbiome of the chest. And surgical asepsis is usually short-lived, and the organism can recolonize the wound edges within 30 minutes, leading to direct contamination intraoperatively because there is still no endothelialization. So the organism is of low pathogenicity, so it eats up the valve slowly, and the biofilm can explain to us the resistance and relapse rate. Hence, my final diagnosis.
Thank you very much. And now some questions from our judges.
Okay, so Cutibacterium acnes is your organism. A very highly sensitive organism, low virulent. So why do you think it recurred so quickly after the first course?
Doctor, according to my readings, doctor, it is actually very known to cause treatment relapse and treatment failure despite very effective and appropriate antimicrobial agents. They associate this to the biofilm formation created by the organism. And also, doctor, I think I went with the organism based on the fact that he had very little exposures. He did not really need much, he was not really immunocompromised. So the only risk factor that you need for this organism is just open chest surgery itself.
Okay. So looking back in retrospect, what would you have done differently when you admitted this case on May 31st?
I think, Doctor, early surgery would have been a good suggestion for the patient since source control is still significant in controlling this infection.
And what would you treat the organism with?
Usually the drug of choice is penicillin, but they usually also respond with cephalosporins and vancomycin as well. Thank you, doctors.
Thank you very much to our judges and all of our case presenters for today. At this point in time, we'd like to introduce our judges for this year. Our first judge is a consultant at the Division of Infectious Diseases, Department of Internal Medicine, Mayo Clinic, Rochester, Minnesota. Professor of Medicine at Mayo Clinic College of Medicine and Science, Rochester, Minnesota. Chair, Community Infectious Disease Practice, Department of Medicine, Division of Infectious Diseases. Vice Chair, Division of Infectious Diseases, Department of Internal Medicine at Mayo Clinic. Please welcome Dr. Raymund Razonable. Our second judge is an assistant professor, Department of Family Medicine at the University of Pittsburgh, UPMC McKeesport. Assistant professor, HIV/AIDS Program, Department of Infectious Diseases, University of Pittsburgh. Director, HIV and Hepatitis C, UPMC McKeesport Family Medicine Residency Program. We have Dr. Gordon Liu. And our third judge is Leader Diagnostics Network Medicine Sans Frontiers International Geneva, Switzerland, former technical officer, research ethics and knowledgeable uptake, and team member of R&D Blueprint World Health Organization in Geneva, Switzerland. Former senior consultant, Department of Infectious Diseases, and head of HIV program, Tan Tock Seng Hospital, Singapore. Consulting reviewer for the following medical journals: PLOS ONE, AIDS Research and Therapy, Sexual Transmitted Infections, Transactions of the Royal Society of Tropical Medicine and Hygiene, BMC Infectious Diseases, Annals of Behavioral Medicine, Annals of Academy of Medicine in Singapore, and Singapore Medical Journal. Please welcome Dr. Arlene Christine Chua. And now we'd like to invite our three judges on stage. To join them, we have Dr. Mario Panaligan, or Margo Panaligan, Dr. Maffy Tyson, to present the certificate of appreciations for judges.
They're still grading.
Sabihin mo na lang. Wag na muna. Wag muna. Perhaps what we can do is acknowledge our judges later because they want more time as they evaluate because I think the scores are really so close to each other, okay? So let's just give our judges some more time and we're going to give them their certificates and acknowledge them later.
Pasok lang. No need to compute.
Thank you. Our judges will select the winners for this year's PPRISM based, again, on the following criteria. Relevance of question asks or pre-evaluated will be 10 points. Case analysis and data integration, 30 points. Differential diagnosis, 20 points. Presentation, content, and organization, 25 points. Visual aids, 5 points. Ability to answer question, 5 points. And primary clinical impression will be 5 points. This year's prizes are 3 consolation prizes of 5,000 pesos worth of CME grant. The institution that will bag the 3rd place will get a CME grant of 10,000 pesos and a local convention sponsorship, while the 2nd place winner takes 15,000 pesos and a local convention sponsorship. And the Grand PPRISM winner will receive 20,000 pesos and original convention sponsorship. We will now pause for a moment for our final diagnosis. Let us now welcome on stage Dr. Raul Distura to give us the final diagnosis.
Good morning, everyone. Exciting case, ano? I just find it a little bit odd kasi parang lagi na lang ako. This is the 3rd year that my patients are actually being chosen for PPRISM. Malas lang siguro nare-refer sa akin. Okay, so there are a lot of areas for these patients. Was actually an ID challenge in terms of management. Several factors affecting the behavior of treatment was largely based on the patient's profile. It's actually ability to tolerate standard recipe book regimens for treating infections. But in the real world, you have to recalibrate each time because the patient doesn't respond the way they should be in terms of tolerating treatment. Okay, that's my excuse. So the trans-echocardiogram, transesophageal echocardiogram revealed this particular linear echogenic density in the posterior wall, which you all agree that it could be a case of infective endocarditis. The cultures showed AFB smear positivity. Why did it took a while to be diagnosed? principally because when in standard typical microbiology lab, when the blood culture turns positive, the usual reaction is to do a smear of the blood culture bottle, the usual gram stain. And we all know that specific organisms sometimes do not adhere to the staining, and they don't see it on the microscope. But the good thing about it is, aside from that, you make a smear on the primary isolation media, and that is your blood culture. So when it grew, and then we looked at the characteristic, colony characteristics and the microscopic features, we realized that this is a weird bug growing from the isolate. So we have, at the hospital where this was admitted, I actually set up a PCR technology that discriminates between Mycobacterium tuberculosis and non-tuberculous mycobacteria. And all of them tested negative for MTB, but all of them tested positive for NTM. So basically, we're dealing with non-tuberculous Mycobacterium prosthetic valve endocarditis. And like any other endovascular infections, we monitor response to treatment by repeating our cultures to make sure that there is conversion. And obviously, after we revised some of the regimens, there were already culture negativity repeatedly. When we tested and screened for all other sites, no, he also tested positive actually for NTM in the respiratory, but clinically the lungs are clear. Maybe it's just really a colonizer or tinamaan na rin with the treatment. No? There were no direct evidence when I saw the patient because he was referred to me during the second admission already. When crucial to the treatment of a non-tuberculous mycobacterium is really the identification of what it is, principally because there are specific regimens per species of the non-tuberculous mycobacterium. But at that time, we didn't have the ability to identify it using phenotypic means, so I have to do 16S ribosomal sequencing in my other lab at the NIH. But this happened a little later because it takes a while to prepare the library preps and do the capillary sequencing. So what I did was I just look at the most likely NTM that we will be dealing with between abscessus, fortuitum, coloniars, or chelonae are the usual ones that we see. So I have to tailor treatment that should at least hit 80% of those three. So while we were waiting for the identification, the patient actually improved and there was conversion from culture positivity to culture negativity. The problem was, knowing that this is prosthetic valve endocarditis of the non-tuberculous origin, the treatment is really a challenge because a lot of failure happens even if you give the best interventions. So ideally, this patient should undergo removal of the prosthetic valve and replacing them, but the timing, when, how, and whether the patient will survive, take note, it will be the third open heart surgery, if ever. So you could just imagine the forest inside the thoracic cage, no? And all those adhesions that thoracic surgeons will have to do. But the family didn't want the surgery, so we have to follow their wishes. So I suggested OPAT, outpatient antibiotic therapy, and I was able to convince them to have a peripheral inserted central cath inserted so that they can be treated with an IV antibiotics even in the outpatient, with a warning that this is bound to fail. But I think as a family, pag nakikita na nila na something is still off despite of the effervescence and partial response to treatment. When we repeated the echo from a 1/4 leak became 1/2. So it became now an urgency, and the patient was again having symptoms suggestive of failing heart. And we were able to convince them for a readmission and a third open heart surgery. So we were all praying that he makes it at that time, but I'm glad that the surgeon was able to remove this valve. At the 10 o'clock position, you can actually see the vegetations there. And microscopically, I still saw the FB smear positivity in that area, but the tissue didn't grow anymore. So during this treatment, because of we were able to tide him over and was able to sustain the surgery because he was repeatedly culture negative. And I was informing the team that this is the right time. If we're gonna do this, we have to do it now, because if the leak progresses more than 1/2, then that's it. We're gonna have an emergency cardiothoracic surgery, and the mortality outcomes may be higher. And the good news is the patient survived the surgery the 3rd time. So the 16S ribosomal testing took us about 21 days to process the whole thing because of the logistics. And turned out to be Mycobacterium fortuitum, for which the current regimen were actually dedicated to this particular organism. So we didn't change our regimen. Yes. Sorry, that was the last na pala. Yes. So basically just an update. The patient, I saw the patient last week, and he's up and about, and he remains culture negative. Separate, I don't know the standard duration for which you should treat this particular patients, because there are not so many cases you see globally. So the clinical basis of response has always been whether the patient will persistently culture negative. So far, patient is culture negative, up and about, happy, and I'm hoping that there won't be any further resurgence of the infection so far. But all of the cultures over the last 12 weeks are all negative. I think this is the 3rd month culture negativity from all sides. Thank you.
Thank you very much, Dr. Raul Destura. Again, I'd like to invite our judges for this event to join us at the stage. Dr. Arlene Christine Chua, Dr. Gordon Liu, and Dr. Raymund. And to officiate the giving of the Certificate of Appreciation is Dr. Mario Banaligan and Dr. Matthew Tyson.
May we request Dr. Razonable to announce now our winners? Maybe I'll just hold on to this for a while.
So I announce the consolations first, or? All right, consolations first. Not in particular order. Okay. So the 3 consolations are Dr. Noreen Matiga from San Lazaro. Are they supposed to come up? All right. The second consolation is Dr. Sheena Marie Santos of St. Luke's Medical Center. And the third consolation is Dr. Diana Ramos from RITM. Okay, the moment of truth. Third place. Tinan ko muna, baka mamaya naduling ako. Hindi pa? Hindi pwede magkamali. Dr. Mark Peralta, UST.
We will also request Dr. Rhonda Bergantine to join us on stage.
Second place. Naku, hindi ako dapat pwede magkamali dito. Second place is, here. Dr. Maurice Nepomuceno of PGH.
Joining our second place winner is our training officer, Dr. Sonia Salama.
And of course, there's only one left, right? It's the first time, the Grand PRISM. I don't see Makati Medical Center in the banner here yet, but they're gonna be the winner, Dr. Erica Caperona of Makati Medical.
May we also request their training officer, Dr. Blair, to join us on stage. Thank you very much to our judges, and congratulations, Makati Medical Center, for being our champion in the 11th Grand PPRISM. And now let's hear a few words from Pfizer's Country Portfolio Manager, Mr. Donnie Pascual.
Before Mr. Pascual, I'd like to, of course, allow our dear President, Dr. Mario Panaligan, to say something.
Again, congratulations to Makati Med. And then, for the past 11 years, Pfizer has been very, very helpful to us as the company helps sustain this particular event. And through the years, of course, since 2008, this was the MOA signing. And you can see that from then on, we conduct regular conferences every other month. And moving fast forward, and many, many thanks to Pfizer for the 11 years of great work. Thank you very much. Thanks a lot. And as I've announced in the business meeting yesterday, of course, we recognize, of course, the work and the compassion and the greatness of this man who helped us, who left us actually last year, December 22, 2017. And so we are launching, of course, next year with the new format that was discussed earlier by Dr. Ramaki Tyson, we are now renaming it as PRISM. PSMIDs recognize intricacies, synchronized mechanisms. The Dr. Manolito L. Chua Memorial Fellows Clinical Pathological Conferences. So next year again, see you. And I think we'll have a new training program. We'll have a new training institution, hopefully. Yeah, and that's the medical city. So there will be seven fellows who will be discussing, of course, the clinical pathology conference. Again, thank you very much, Pfizer, and thanks to all.
May we request our dear President to stay on the stage. And we would like, of course, to call on so that we can acknowledge properly and give our deepest gratitude Mr. Rene Carlos or Don D. Pascual to come on stage. And as a token of appreciation, and as I've said, symbol of friendship of PSMID to Pfizer Philippines Incorporated, we would like to present this memento. It says here, plaque of recognition to Pfizer Philippines Incorporated in grateful appreciation of your unwavering support to the PSMID-Pfizer Interactive Anti-Infective Consensus Meeting in the last 11 years. So again, to Pfizer, thank you very, very much. And we would like to ask Don D for some words.
Thank you. Maybe I'll stay here. Maraming salamat, Dr. Mario. Maraming salamat, Dr. Mafi. Adios, patria adorada. Región del sol querida, perla del mar de oriente, nuestro perdido Eden. Mi último adios to my fellow countrymen, my dear doctors and audience. It has been, again, a very informative conference we had for the past few days and for the past 11 years. I am sure we are all going home, not only with the learnings, but also with deep appreciation of the beauty of innovative treatment of infectious diseases. Similarly to Rizal and our celebrated hero, Andres Bonifacio, we are the 21st century heroes. We are the new leaders in the field of medicine, wishing or using knowledge as our sword and power, we can create impact, and it should start with us. 155 years had passed since the death of Andres Bonifacio. And like our national heroes, we don't easily forget them because they are not only written in our mind, but in our hearts as well. Oo, nasa puso natin sila. Maipagpapatuloy lang natin ang ating laban kung ilalagay natin ito sa ating mga puso. At ang ating pagtatapos, muling aking ipapaalala na ang tanging sandata ay ang ating malinis na konsensya, malalim na kaalaman sa medisina at nagkukuta na pananalig sa dakong huli ang katarungan, ang gigitaw ng buong tagumpay ng PSMID. Maraming salamat po sa 11 taon na pagsasama. Para sa amin, ito ay mananatiling isang buhay na alaala. Magandang umaga po sa inyong lahat.
Thank you very much, Mr. Donnie Pascual. And would like to thank all our members of the panel of judges once again, to all the staff who made PPRISM of a very successful event. And this year's PSMID-Pfizer Interactive Consensus Meeting has come to an end. Congratulations to all the winners and the 11th Grand Prix PPRISM champion, Makati Medical Center. Thank you for spending your morning with us. We wish you all well and enjoy the rest of the day.